Good morning, everybody. My name is Igor Koutsenok, and it's a pleasure being with you today. I'm an addiction psychiatrist, born in Ukraine, trained at St. George's Hospital Medical School at the University of London in the UK, and I did my residency in general psychiatry and then fellowship in addiction psychiatry. Since 1996, I'm a faculty member at the University of California, San Diego Department of Psychiatry. I'm a professor of psychiatry here. So I have my kind of personal cross-cultural experience that is relevant actually to the subject. Also, I've been appointed the Director of Treatment and Rehabilitation at the United Nations Office of Drugs and Crime. This is the UN, a major UN office in Vienna. I used to live there for a period of time doing some work globally, which again, I'm not sharing it for the sake of bragging, but rather to show you that I have both personal and professional experiences globally around the world, and it is relevant to the understanding of the issue of motivation, the issue of language, the issue of language as an expression of our thinking processes in multiple cultures, and the United States is a cross-cultural environment, so this is something that most likely you will be professionally subjected or already subjected to, and you have to have some appreciation of different verbal expressions in different cultures and patients coming from different cultures. Today, I will try to talk about the issue of language, relevant to the motivational enhancement, the human motivation in general, motivation of doing or not doing things, and how can you practically and clinically use some of the material that I will try to share with you. My hope is you will be able to do it practically, essentially maybe starting tomorrow morning, if you're willing to try. So let's talk about the language, the motivation, and everything related to this quite large construct. These are my children when they were young. You see on the left side, this is my son sitting on a branch and being very hesitant about jumping. A part of him tells him, yeah, go ahead, jump. And there are some kids around here, they're not in the picture, telling him, come on, jump, it's fun. And yet he's quite hesitant. It doesn't look very safe idea to him. So he's very ambivalent about jumping. So there are two parts in him, and they're fighting with each other. And you see on the right side, these are my boys jumping, flying, and actually having fun. So apparently something conceptually, cognitively, emotionally, something have changed drastically. There's a major shift between this state of contemplation, should I or I should know, to that stage, to actually action, doing something. And not just doing something, but enjoying the success, enjoying the fun of it, enjoying the result. There is a major change, conceptual change between these two pictures. And this is what we call the ambivalence. In motivational interviewing, there are a couple of important concepts that I'm sure you're familiar with. Being ambivalent is normal. Ambivalence is not a symptom of anything. It's not a symptom of any pathology. It's a normal human behavior and cognitive construct. Every patient coming to your office to see you is ambivalent by default, because people don't like going to doctors. They do go when they have to, when there is something that bothers them and they have to see a doctor. So every patient, particularly relevant to drug and alcohol and addiction medicine, this is what my area of expertise is, every patient I've seen in 35 years of my professional career is ambivalent by default, and I know that, and they know that, and they know that I know it. Another important concept here, relevant to human motivation, to do or not to do, whatever it is, Motivation is very dynamic. Human motivation changes in minutes. And in fact, if you think about it, working with clients' motivation is the therapist problem. It's not the client problem. We need to learn, we need to train ourselves what we can do to assist people to go through the period of ambivalence, to address the ambivalence in a very strategic and meaningful way, to assist the person to do something differently that maybe would be a better option and make the life better and healthier and more functional. Another important concept that I would like to remind you, because I presume you probably know it already. Most people, even very dysfunctional people, have pretty good ideas what to do in order to make their life better. Most people know the solutions. People don't necessarily follow through, but they know what the solution is. So the last thing I want to do is to tell people, here is what you got to do. Here is what you need to do. You need to lose weight. You need to quit smoking. You need to quit drinking. You need to exercise more. Because guess what? There is almost 100% likelihood, probability, that I'm not telling anything that this person doesn't know, or this person, at least this person had ever considered. So if I tell people things that they already know, essentially the message I'm sending to the person, you're incompetent. And if I send this message to you, you will become very defensive, rightfully so. And this is the last thing I want to see in a patient. The last thing I want to see is a defensive patient, because that automatically will make the patient less rational, and it will be much more difficult for me to work with the patient. One of the key skills in working with ambivalent people in general, regardless what type of intervention or what type of skills you would like to use, is the skill of listening. It's as simple as it sounds, because it does sound like a very simple and common sense concept. But this is not as simple as most people think, even professionals, even mental health professionals. Let's talk about the intent of listening. Why are we listening? Unfortunately, for a variety of reasons, since early childhood, we are conditioned to listen with the intent to respond. If you think about it, go back to your recollection, the last couple of conversations you had, not just with the patient, with your colleagues or with your family. When we listen somebody's talking, we automatically, in our brain, we already build a way to respond. We don't still understand what the person is saying, but we are already ready to respond. So what I'm trying to say is, we are conditioned culturally, and by the way, it is very cross-cultural phenomenon. It's not just here. We are conditioned to listen with the intent to respond rather than the intent to understand. And this is a challenge. This is a challenge for any normal human communication. I'm not just talking about medical profession. In general, the human communication. We rarely listen to somebody with the intent to understand what this person is saying, particularly if the person is saying something that is inconsistent with your point of view. As soon as we hear something like that, we are ready to fight. Or at least we are ready to defend our point of view, and now we are in an argument. It's interesting to remember the work of a great British psychologist by the name of Thomas Gordon, who had done a lifelong research on listening and related fields. What listening is not: asking questions, agreeing, praising, approving, disapproving, advising, suggesting, arguing, persuading, interpreting, assuring, sympathizing. None of these things. They may be quite important for human communication, but they are not a sign of good listening. Neither giving directions or commanding people, or warning or threatening, or moralizing, agreeing, disagreeing, judging, criticizing. These are the things that we are doing all the time. We're doing it at least once an hour every day. We don't think about it. As soon as we get involved in this type of interactions with another human being, it almost automatically means that we are actually not listening. We are responding in a certain way. And I'm not saying this is necessarily a bad thing. I'm saying this is just not a part of good listening. In motivational interviewing and similar strategies that we are discussing today, in any attempt to assist the person to deal with the issue of ambivalence, meaning the hesitation, should I or I should not, empathetic listening and careful listening actually helps us to understand where this person is coming from. What is the source of the thoughts, emotions, actions, even if you totally disagree with that. And this is the essence of empathy. That's what empathy is. And the way we show the empathetic attitude to our patients is exactly because of the careful listening, even if what the person is saying is not consistent with your point of view. And I'm not talking just about listening for the sake of becoming a kind of a good person. You're good people anyway. You don't need me for that. No, by listening, I mean quite specific and quite strategic way of listening. Listening for what? In brief action planning, in motivation enhancement therapies, in motivational interviewing, and in fact, in any kind of behavioral interventions. If we really want to assist people addressing a very common problem of ambivalence, regardless of your school of thought, it could be psychodynamically oriented, psychoanalytically oriented, Gestalt therapist, it doesn't really matter. When we listen, and particularly listen with the intent to understand and they assist people strategically to navigate through their ambivalence, hesitation, we're listening essentially for two verbal expressions of the ambivalence. Ambivalence is a psychological construct, but we recognize that people are ambivalent by listening what they're saying and doing it in a very specific way. Essentially, we are listening for two types of statements that actually show how ambivalent this person is. And these two parts of statements, we call them change talk and sustain talk. And actually, this is quite simple concept. Change talk is everything that the person is saying in favor of potential to change something, at least to start moving in the direction of a change. The change may not, the change hasn't happened yet, but that actually doesn't matter. Because for many, many years, starting with Carl Rogers and the Rogerian Client Center psychotherapy, we know, both from our clinical experience and particularly from a lot of science behind it, there are tons of research suggesting pretty much the same thing. The more the client, the patient is talking about the potential of change, the more likely this change will actually happen. So the change talk, everything that the person says in favor of changing or doing something or considering the change, is actually highly predictive of a real behavioral change. The second half, the second part of the statements that we are listening for is just the opposite part of the ambivalence. And we call it a sustained talk. Sustained talk is everything that the person says in favor of keeping its status quo. Do not change anything. And guess what? The sustained talk is very predictive of no change. The important issue here is that in every patient you're seeing, within almost every sentence, or certainly within a single interview, you will hear both. Both parts of the statements, the sustained talk and the change talk, are always present. but they're present in different proportions. You may be lucky that you have a patient who had already addressed a big part of this, of the ambivalence, and this patient might give you quite a lot of change talk right away. You just need to recognize it. Or you might have a patient who is highly ambivalent, very hesitant, what we used to call, and sometimes we still call, a patient in denial, a construct that there is no science to prove that this construct does exist, the construct of denial. What does exist is very high level of ambivalence. And in that case, you will get a lot of sustained talk from the patient. But even if you listen a patient who is very ambivalent and gives you a bunch of sustained talk, meaning statements why nothing can change or he or she is not interested in changing, there always, if we listen carefully, there will be a small part of the statements that will resemble a change talk. It is like gold mining. You see on this picture, the people who are staying in a cold river with a pan, with a net underneath it. They're trying to get some pieces of gold, nuggets of gold from the bottom of the river. It's cold. It's not particularly entertaining exercise, but people are looking for gold. So they grab the sand from the bottom, and then what happens? They sift it, and they pay very close attention. They do not ignore the sand. They just let it go back. We don't respond to the sand. The sand is not what we need. I'm looking for gold. Again, I'm not ignoring anything. I'm paying very close attention, looking at what do I have in my hands. I grab the sand from the bottom. There is no gold. I let the sand go. I did not react. I did not do anything. I made a couple of steps left or right. I did it again. No gold. I moved again. No gold. I moved for the fourth time. Now I grab the sand from the bottom. Aha. I just got a small piece of gold. A bunch of sand, and I let it go back to the river. That's not what I'm interested in. But I just got a small piece of gold. What does it tell me? It tells me don't move. It tells me that since I got a piece of gold here at this spot, I might get some more. And this is what I'm looking for. I'm not moving. I'm digging, and I'm paying attention, very close attention, and I'm reinforcing only the piece of gold. So this is, in fact, the metaphor about strategic listening and making a difference, making a differentiation between change talk and sustained talk. Because what makes a motivational interviewing as directive and strategic approach is it is my clinical skills and my training that will tell me what to respond and what not to respond to. Because since I know from the science, the more the patient is talking about the potential of change, automatically it makes it more likely that the change will happen. So I want more of it. I'm not moving when I hear it. I want to reinforce it. I'm not ignoring the sustained talk either. I just do not respond to that. Why? Because I don't want to reinforce the sustained talk. At some point in the interview, we might do some response to this, some more advanced training. We might respond to the sustained talk, but in general, my clinical skills and my training will actually tell me what to respond to and what not to respond to. And I would be very interested in responding and reinforcing the change talk. But prior to doing that, we need to train our listening devices, how to recognize change talk and sustained talk. Let's do a little bit of practicing.